Our very last topic is going to be GYN, and this is our final frontier. Yay! Are y'all good for this? Okay, let's see if we can see what we can do. We're going to start off with our first topic in this particular chapter. Is going to be on enuresis. And enuresis, as you know, is a condition whereby the child has incontinence. And the incontinence basically occurs, voluntary control should occur. They maybe they've had continence and then they became incontinent, which is right here. They were dry and then all of a sudden they become a bedwetter again. Or primary means they never developed control. And if you'll see here, you can have nighttime incontinence during sleep or diurnal during waking hours. So you have a variety of different types. When we think about our bedwetters, we've got up to 40% 3-year-olds, 10% 5-year-olds, and even up to 10-year-olds. Think about a 10-year-old trying to go to camp. Think about them having to spend the night. So it can be very challenging for them. We do know that and it says 95% of the cases are functional. Whereas a lot of times we think of enuresis being associated with kids that have emotional disorders. That can also contribute greatly to it. Whenever you have a child that is having enuresis, you want to think about always, is it a UTI? Always do a UA in a culture. You also want to think about some of the treatment modalities. Well, enuresis alarms and positive reinforcement charts and giving them little stars and things like that. Bladder control training geared towards training the bladder to hold more urine. That can be helpful. There are medications. Look at the meds. Imipramine, DDAVP, which is desmopressin, Ditropan, which we use for what? Women. Detrol, right? That's the main ingredient. You can see all these, but guess what? Kids that are placed on these medications, they need drug holidays from them. You can't keep them on forever. They need to periodically come off. And whenever they come off of it, guess what's going to occur? Recurrence. So you want to think about that. But guess what is the most effective treatment, believe it or not? Hypnosis and self-hypnotherapy. I'm actually trained in hypnotherapy. I use it in my practice. And I know that sounds strange that would be so effective, but it is highly effective. The problem is insurance doesn't always cover it. But it does work very, very well. It works because a lot of kids are anxious, and it works great with anxiety. You also want to treat a UTI, and that leads us into UTIs. You know this is a pink pig. UTIs are going to be on the test. We think about, for instance, males who are uncircumcised first year, and those that are females throughout the rest of the lifespan. We think about what are your main agents, your E. coli and your Staph aureus. Staph aureus usually for your complicated UTIs, your E. coli for uncomplicated. Well, we also know there could be predisposing factors such as urinary stasis, lesions that are obstructive or a neurogenic bladder. You can also have kids that have reflux, renal scarring. This is one of the reasons. Remember earlier I told you we don't do UAs on scheduled times? We do UAs now. Remember they pulled that off? It used to be they do it at certain times. They now pulled it off and said you do it as indicated. So if you have a child that you know has had frequent UTIs, you probably need to be monitoring them more closely because of what? Renal scarring and hypertension and renal failure. Infants that have UTIs have weight loss, failure to thrive, dehydration, and they're irritable. Your adolescents may have some pain, urgency, suprapubic discomfort, hematuria, fever. You know, you need to get a good sample, so either straight cath them when they need to get as indicated, and they can't void voluntarily. For your follow-ups, it's okay to do clean catches. UA, you're going to check your leukocytes, erythrocytes, nitrites. You're going to check also a CBC to make sure that aspect, that they're not showing an infection. Look at your medications, Bactrim, your cephalosporins, amoxicillin, nitrofurantoin. So you've got several choices. And what AAP says is that follow up in 2 days and change the antibiotic if there's no improvement seen. Follow up then in 1 to 2 weeks, and then every 1 to 3 months for a year. So whenever the child comes for one of these appointments, you need to do a UA and a culture, okay? We also know encourage fluids, frequent voiding. How many of y'all saw the movie Bucket List Isn't that a great movie? That movie, remember Jack Nicholson at the very end said there were 3 things in life that he would never miss? Guess what one of them was? I won't tell you all 3 of them, but the first one was never miss the opportunity to go to the bathroom. I love that. I think about that because I have, soon to be 8 grandchildren. When we travel with the kids to Disney World or something, you stop to go to the bathroom on the road, everybody's going to the bathroom. You don't want to hear any whining. You want them to avoid, right? And so avoiding cyst or urethrogram and antimicrobial prophylaxis is not indicated after the first febrile UTI. Let me make a point here, especially for the peds folks who have probably been following this. It used to be until back in October of 2011, we always did antimicrobial prophylaxis and we also did VCUGs. They now have come up with, it's a controversy now. They haven't settled it out, what they want us to do. So stay tuned. There's probably going to be some changes on how we manage UTIs in terms of prophylaxis and VCUGs. So just stay tuned for that. We also know that, if you have somebody who has a renal abnormality, hydronephrosis or scarring, high-grade reflux, all of those would be very important. We did hypospadias earlier. That was the penis that had the ventral opening, the opening on the ventral side. I pretty much covered that, but the thing I want to point out to you is, you can have it hooded with the foreskin. The urinary stream is aimed downward. Chordee may be a little bowing of the penis. We are going to do what? Refer them to a urologist. Circumcision may not be done until they then are prepared to do the surgical reconstruction of the whole site and the circumcision at the same time. Here's that term, Cryptorchidism, fancy term for what? Absence of one or both testes in the scrotal sac due to failure to descend from the abdomen in utero. And didn't I mention to you that this occurs in the last trimester? So your preemies, 3% of newborn males and 20 to 30% of preemies, it's a very common event. The thing I want you to take away from here is, it's very hard sometimes to give enough pressure so that the little testicle doesn't slide up into the canal. So you want to make sure you give enough pressure to do that. But you can do karyotyping. The urologist may do that if they felt there was a need because of a chromosomal abnormality. But really, what you want to do is when you have undescended testicles after a year, you want to refer them to a urologist. And here's a pink pig, something fairly recently. I want you to know, when would you teach, anybody that had a history of cryptorchidism, remember I mentioned earlier, testicular cancer, 38 to 50%. You need to teach these young adolescent males to do TSE. There is a test question that I have heard from students that it says they give you ranges of when you would teach them. Now, normally I would teach an adolescent, the answer was 15 to 20. That to me is too late because a 15-year-old is not going to want to start doing testicular self-examination for the first time. Usually you want to get them earlier, say around 11, 12, so they get into the routine of examining themselves and feeling comfortable with it. Does that make sense? So just be aware of that. Testicular torsion, this is the somatic cord. It's been twisted, acute pain. It's a surgical emergency. As a matter of fact, they say get them into surgery within 6 hours. The testicle can be necrotic as well as infertility. Pretty much the information I want you to take away from here, there's nothing that looks infectious about it. It's just twisted. So surgery is important. You think you're going to see a child with dysmenorrhea in practice? Oh my goodness. Yes, strap in. Pain and cramping associated with the menses. We have what's considered primary, which means there's no pelvic pathology, most commonly seen in adolescents where they may have a hormone or endocrine-related situation. Primary dysmenorrhea typically begins around 6 to 12 months after menarche, and symptoms gradually increase until the patients are in their mid-20s. Secondary dysmenorrhea is usually associated to what? A secondary reason, like PID, endometriosis. So what happens here? You got to clear that problem up first so that the dysmenorrhea associated with it will be relieved. Usually you got painful menses, lower abdominal pain, typically the first few days of the cycle, associated back pain, may have fatigue, headache, and diarrhea. Primary, no testing. Secondary, you'll test for whatever you think you're considered considering in terms of the primary reason. You're going to do a lot of education and supportive measures, heat application, over-the-counter medications, analgesics. Sometimes putting them on a birth control pill to help regulate will also help relieve that. You may see stronger NSAIDs like ibuprofen or Ponstil or naproxen, naproxen. All of those will be helpful. Now we're going to take a brief journey through STDs and STIs. This is referred to, what is the most common STD that we're concerned with teenagers? Chlamydia. And do you know that chlamydia is not necessarily reported in every state, even though we report what? What does every state require STD-wise? Usually gonorrhea, syphilis, TB as a condition, and HIV, but not every state requires chlamydia. Even though we know gonorrhea, we treat for chlamydia. Isn't that interesting? So know what your state requires. It's a bacterial STD. It's the most common bacterial STD in the U.S. The thing I want you to take away from here is it causes cervicitis and urethritis in teenagers, but it's often asymptomatic. They don't even know they have it. So if there are symptoms, dysuria, intramenstrual spotting, postcoital bleeding, dyspareunia, vaginal discharge, lower abdominal pelvic pain. In males, thick, cloudy penile discharge, dysuria, or testicular pain. Again, either asymptomatic predominantly, but they may have symptoms. We do a culture, but who has 9 days for the teenager, right? So you want to do something like a quick urine test, an EIA screening. You can get it in, say, 30 minutes to maybe an hour and a half, low cost, and you can treat them. How do we treat them? Usually we give a dose of Zithromax, a gram orally, as a single dose, but you could go with doxycycline. Both of these are considered STD first line. Now we mentioned, CDC first line. Earlier we talked about medications. This would be one area where they may ask you about a medication, okay, because of guidelines. Here's gonorrhea, gram-negative organism. We think about it leads to infertility among females. Females, they're often asymptomatic, but if you had symptoms, maybe dysuria, frequency, a little vaginal discharge that's mucopurulent, some labial pain, swelling, lower abdominal pain, fever, dysmenorrhea, some nausea, vomiting. And for your males, again, they're often asymptomatic. If they do have symptoms, you may see dysuria, frequency, white, yellow, green penile discharge, which is the classic discharge, and testicular pain. Pretty much that good old gram stain, and of course a cervical culture, which we do when we do paps and pelvics. The treatment of choice is Rocephin. When we treat them with Rocephin, we have to treat for chlamydia. We already talked about chlamydial treatment earlier. Report to the health department. Here is syphilis. Now, syphilis is a spirochete. It does cross the placenta, and we do know that it's primary and secondary, and we got stages. Let me back up and say the stages are primary, secondary, tertiary, latent. So we want to think about in primary, that's when you get what? A lesion, newly positive, and you can pick that up on a dark field microscopy for the treponines. Secondary, we think about doing a syphilis screen, and then we're going to do some serology testing for untreated syphilis. So this is going to be important. But when we stage them, let's talk about staging. You got the chancre or the lesion that may or may not be noted because it's often painless. This usually appears 2 to 6 weeks after exposure. You're probably going to have the patient complain of some adenopathy. Then you think about 6 to 8 weeks later, they move into a secondary stage, flu, adenopathy, maculopapular rash, palm, soles, buccal mucosa. We talked about that earlier. In the latent phase, this is where you are asymptomatic, and which a third of the cases then move on to that neurosyphilis tertiary phase. And that's where you get leukoplakia, you get cardiac involvement such as the aneurysms, regurgitation, aortitis, tumors in the skin, bone, and liver, and central nervous system involvement. That's why we call that stage CNS the neurosyphilis stage. Because let's think about what we normally do in practice. When we screen, we usually do a VDRL RPR. Pretty cheap testing to do. And it comes up positive. What do most people do? We give them penicillin. But what you're supposed to do is this. After you do the screening test, you're supposed to confirm it, do a confirmatory test, which is this FTABAS, which is a fluorescent treponemal antibody absorption test that confirms it, okay? So that's really key. So you're supposed to do a two-step process, screen and confirm. And you can see here management is by the use of penicillin. For those that are penicillin allergic, doxy and erythromycin, and again, we report to the health department. Now, bacterial vaginosis is really not an STD, but we put it in here because it's seen among women who are sexually active, childbearing age. It increases the pH and the lactobacillus is decreased. This is where you have the milky discharge, the very strong fishy discharge, malodorous smell. The pruritus is noted. Cervical, uterine, adnexal areas are all within normal limits. You're not going to have CMT, which is what? Cervical motion tenderness. On doing a wet mount, looking at clue cells, the epithelial cells are striped with bacteria. If you looked under a microscope, there's decreased lactobacilli, fewer or absent WBCs, and there's that positive whiff test. And how are we going to treat them? Good old flagyl or Clindamycin. Clindamycin is really quite popular to use it, and you can give it either PO or intravaginally. Okay? Herpes. Herpes is a virus. It's recurrent. And once you've had your first, you think about herpes, a lot of people refer to herpes type 1, what? Above the waist, in the lip area, the facial area, the mucosa. And that which is considered type 2 is usually considered down into the genitalia. Direct contact with the lesions or the secretions can occur during the birth process. Initially, your first outbreak is quite painful, lasting up, about 10 days or so. Recurrence usually less painful, pruritic ulcers, less number of days that you're dealing with it. We could do a viral culture, but most of us rely on the clinical picture, the symptoms that they present. And so there's no cure to it. We treat them symptomatically with drying antipyretic agents because remember they're vesicles that are very, very painful. You also want to think about your treatment options. You got acyclovir. Acyclovir is approved down to the age of 6 months. Topical oral IV, pregnancy B, so it's very safe. Even though it says 2 years, they changed it down to 6 months. I just wanted to tell you that was a fairly new recommendation. And we've got Valtrex. Valtrex is especially useful for asymptomatic viral shedding. Okay? And our very last topic, here we go, very last, and I won't make it difficult for you. What I want you to think about, because you know what, there's a lot we could talk about with AIDS and HIV. But we know it's important, especially with children, because it's a maternal infant perinatal transmission, and it's also transmitted through breast milk. In our country, we don't recommend mothers that are HIV positive to breastfeed. In other third world countries, they don't have other resources, so they breastfeed. That's because of the transmission. We also know that in infants, they may have low birth weight, recurrent infection, diminished activity, developmental delay, all the things that you're looking for in a newborn, as well as enlarged organs. Screening in infants require HIV, PCR testing. In older kids, we usually do the ELISA. Pretty sensitive there, as you can see, 99%. And then we always use the good old Western blot to confirm. So you've got your infant PCR, your older child ELISA with the Western blot confirmatory. And I will tell you, they change the timing around all the time. They find new data and whether or not, so I'm not going to have you rely on exactly when you would do that. But I want you to know what the drivers are in terms of a child that's been exposed to HIV, when they might develop AIDS. So let's think about it. There's 3 drivers. You know what I mean by drivers? 3 lab tests. There's an absolute CD4 count, more than 800 is normal. And then you've got the percentage, so that if they're less than 20%, that means their risk of developing AIDS is high. Viral load should be less than 5,000 or 0 or undetectable. Let me give you an example. If you had a patient that had a CD4 count of 200, it's down, right? Normal is more than 800. If you had a CD4 percentage of, say, 14%, Okay? That's showing you that where they are, and their viral load is, and this is a patient I recently had, that's why I'm kind of remembering this, 9,200 copies. Okay? That means that child is revving up again. They're replicating the virus and so forth, and they're moving in that direction. We do know it's very important, while you're not going to be asked questions on the different antiretroviral medications, because you know what? We're giving it in combination anyways, and it's always changing. But we do know it's important to do what? Measure opportunistic infections. You're looking for things like, there it is, there's the word, Girovici. There's your Italian pneumocystis, Girovici pneumoniae. Isn't that interesting? So there you go. And you also have consideration for what other opportunistic infections. There's CMV is up there. What about, more commonly, what about TB? What about syphilis? What about hepatitis, right? Some of those things. But these are some of the more common ones, so we want to think about monitoring this child for it. We also know that your heart therapy, highly active antiretroviral therapy standard, we usually start no later than the patient is at 350. Remember, normal was 800 or greater? So when they're around 350, you're going to start them on this. Drug resistance really kicks in, especially with what? Your children. That's where we learn a lot about this. And refer to an HIV infectious disease specialist. Thank you. Okay? Appreciate your time and attention. I'm clapping to y'all.